Hi, everybody. Thank you so much for joining us today. My name is Nicole Lamberson, and I am a physician assistant and a member of the Medicating Normal team, where I volunteer doing outreach for the film and facilitating important conversations like this one. Today, I'm excited to talk with Dr. Stuart Shipko. Dr. Shipko is a psychiatrist in private practice in Pasadena, California. And he's the author of the books Surviving Panic Disorder, Xanax Withdrawal, and Dr. Shipko's Informed Consent for SSRI Antidepressants. He has over 30 years experience as a psychiatrist and an extensive background in the psychotherapies. He writes for Mad in America on issues relating to SSRI withdrawal, and he has a particular interest in the side effects and withdrawal effects of antidepressants and benzodiazepines, and the need for informed consent when prescribing. So thank you so much for joining us today, Dr. Shipko. I'm really excited about this conversation with you. I've read everything you've written on Mad in America, your informed consent book, and I've cited you multiple times in my own, blog writings, and certainly recommended all of your writings to as resources for others, in SSRI withdrawal or having trouble with SSRI. So you have made a great contribution with the things that you've contributed. And I'm just really glad that you're here to talk today. Before we get started, is there anything I left out of your bio or that you would like to add for?
That's pretty good.
Okay, great. So we'll just jump right in with questions. We are live, so if anyone listening has questions for Dr. Shipko as we go, we'll try to get to them. Please just don't ask, personal medical questions or that kind of thing, because we can't answer that. So first, how did you develop an interest in adverse effects from SSRIs?
Well, the earliest interest actually kind of came about by accident almost. I had one of the first websites on panic disorder in the internet. It was in the early 90s. I don't think there were more than 5 of them. And I was pretty widely read for the internet then. And what I had found in my office was that people were coming in saying that their doctor gave them Prozac or Paxil, which were approved for panic disorder, and they had the worst panic attacks of their life. And I just posted that. I had a FAQ section, and I wrote about that. Well, it turns out that when they approved these drugs for treatment of panic disorder, they gave a benzodiazepine along with it. They didn't just give the drug. And it wasn't well known to the doctors prescribing it, didn't know that. So when I posted that, not only did people contact me who had bad panic attacks from their SSRIs, but literally hundreds of people from all over the country contacted me because doctors weren't willing to even listen to side effects, so that whatever they told the doctor said, that can't happen. And the patients were left out in the cold. It was an amazing phenomena. And, I told the patients that I had nothing to offer them. I didn't know what to do. All they really wanted me to do was sit there and listen, to validate them. So that's where it all started. And then every type of side effect came my way after that, because I was willing to listen. And over a while, you begin to see patterns and know more about it.
Yeah. So when was that? How long ago was it?
Gosh, it would be like 95, 96.
Wow. So you've had a long period of learning since then.
Yeah.
So what are you seeing then as adverse effects from SSRIs? Is it just things when people are trying to stop, or like with benzos, we hear of tolerance withdrawal and interdose withdrawal. So are the SSRIs causing the same tolerance problems as well?
Well, I guess there is that, but I want to mention another thing that Giannini Fava, who's editor of Psychotherapy and Psychosomatics, wrote a great article on SSRI tapering. And he said something that struck me, which was that he trained in an era where you took people off of antidepressants. You didn't just leave them on. Depression was actually defined as a time-limited episodic condition. It was going to get better even if you did nothing. So his experience about SSRI withdrawal came from the idea, well, okay, you're better, let's taper the medicine and stop it. That's what you did with the tricyclics, which apparently they had their own withdrawal problems, but they were much less noticeable. So that was another thing, that people would come in. I didn't prescribe them right away, but people would come in, they'd be doing fine. I'd say, well, okay, it's time to stop the antidepressant. And then literally all hell broke loose over and over again, that you couldn't stop these quite so easily. So right away, withdrawal effects were quite obvious. The other thing, so I had been practicing for years, and I had read about antidepressants causing people to flip from unipolar to bipolar depression. I've never seen a case until the late 80s when Prozac came out. I was seeing people who had SSRI-induced mania. These were the early things. The other thing was sexual dysfunction, where the patients were complaining of inability to get aroused, inability to have an orgasm, more so. And after stopping the medicine, these things persisted. Those were the things that jumped out early on. There's a lot more side effects, that even the manufacturer talks about, the mild ones like bruising and yawning and GI disturbance. But the withdrawal effects, the manic behaviors, the sexual dysfunction. Then, another thing that I don't know whether it was just my bad luck, the suicide issue came up. I can think of one guy, he was an attorney. He was in my social circle. He wasn't doing too bad. He just had a rough patch. And I was giving him Paxil samples. And then I ran out of samples and wrote him a prescription. He didn't have the money to fill it. And he made a suicide attempt out of nowhere. And that was the beginning of me taking a closer look at that. So these things were all pretty apparent right from the beginning.
So we know a lot about, benzo withdrawal in the literature. In your experience, are the withdrawal syndromes much different between the two drug classes?
Now, I've been reading about how the withdrawal syndromes are similar, but that hasn't really been my experience. I confess I have never seen a case of protracted benzodiazepine withdrawal. I've read about it, but I've certainly seen many people with SSRI withdrawal extending for a long time. But with the benzodiazepines, my experience has been more along the lines of headache, insomnia, irritability, not so much the sorts of things. I don't see the zaps and the vertigo. I think that I saw them as kind of different, but I realized that the literature now is pretty much saying that they have the same withdrawal.
Yeah. Well, and I think a lot of people are poly-drugged, and so it's kind of hard to suss out what's causing what too when you're withdrawing from so many things as well.
Well, another thing is that benzodiazepines will cover up a lot of SSRI symptoms and SSRI withdrawal symptoms. And one thing I've wondered about is how much of the so-called similarity between the two is due to the fact that when you take away the benzodiazepine, you're unmasking the problems from the SSRIs. So I know, for example, I had one gentleman where when I took him off of benzodiazepines, he had been on SSRIs for a long time, and we stopped those first. But when we stopped the benzodiazepine, a tardive dyskinesia moved. His tongue was moving. And it went away when we put the benzodiazepine back in. So you wonder how much you're unmasking. I think these are questions that really should be explored further.
Yeah. If they're causing all these adverse effects, what does the science say really about the efficacy of SSRIs? I mean, do they work? What is the benefit?
What does work mean anyway?
Yeah. Well, I guess I mean, what is the risk benefit ratio? And if there are all of these potential issues that you just listed, like I'm just, Joe Schmo on the street and I'm considering taking one, like how am I weighing my risks and benefits here?
Well, the number needed to treat, I think, is 6 or 7, which means for every 7 people who get it, 1 will experience what they consider a beneficial effect, and the other 6 are going to have side effects. So that doesn't seem to be a very good risk-benefit ratio. I also want to talk about when the drug works. I've had patients where I prescribed an SSRI, and then they love it, but they're goofy, they're hypomanic, and then I can't get them to stop it. I guess they would say the drug's working for them, but I wonder if that's what it really is. And also, when we talk about the drug working, they can be very good at making a person sort of numb. And if they're under a lot of stress, that can be beneficial. But I think of one case of a nurse who came to see me. She was raising 3 children as a single parent, which is not so easy to do in Los Angeles. And she was working 2 full-time jobs. And, she had a nice house in a good area. I think 1 or 2 of her kids at least were in private schools. She was working these 2 jobs, and she came in saying she's depressed and she needs something. And I gave her Prozac. This is earlier in my career. I kind of don't even do this anymore. But I gave her Prozac, and she came back and says, it's perfect. This is just perfect. I'm able to do both of my jobs now, and I don't feel stressed. But I remember thinking, well, okay, is this really a positive thing? She's not home very much. Yeah, she's supporting the kids, but was this really in her best interest? Is that what she should have been doing? So when we talk about the drugs working, even that's questionable. But I think when they do work, they make people numb to their experiences. They make them less emotionally reactive. So the people who I thought did best on them were people who are highly traumatized as early children, where they got aggressive instead of assertive. They scream at people easily and uncontrollably. They'd be ruining one job after the next. Those were the people where being less reactive to their internal life actually had a benefit for them. However, where does it go 10 years later? Right.
And we don't really know, do we? I mean, the science doesn't follow people for 10 years taking these.
Science doesn't, but I have. I'm an old man.
Yeah.
So I think of one case in particular of a woman who she just ruined one job after the next. She was a waitress, but she had more education, and she just couldn't move up to a higher position unless she stopped screaming at people, stopped being so overly sensitive to everything everyone said to her. And I remember when I prescribed Prozac for her, I said, this, if it does help you, I can't guarantee that it'll work forever. And you may need to keep raising the dose. And so I followed her for 7 or 8 years. We hardly increased the dose. But then around 9 or 10 years later, she moved out of state. She contacted me and said, well, it happened. The medicine doesn't work anymore for me, and I can't find anything that'll help. It's kind of like Cinderella's coach turning back into a pumpkin. So you see it, and that doesn't mean that everybody, some people might have much more prolonged benefit, but it does wear off. And then where are you? Right. 10 years later, stopping it is difficult.
Gotcha. So I'm going to ask you again about language a little bit later, but I always see, mainstream clinicians who insist like, well, SSRIs are not addictive. They use that phrase. And how do you respond to that? Like, are they just missing the fundamental differences between addiction and physical dependence? Or,
a lot of times when they're talking about addiction, what they are referring to is a person craving more and more of them. Some patients who take benzodiazepines, particularly if they're taking it because they want to shut down a busy mind or for sleep, that's another good one, they need to keep increasing the dose. They want more and more. Benzodiazepines are also drugs of abuse, where people will buy them on the black market and take astounding, unbelievably high doses. So that dosage creep is what they usually refer to as addiction. But people can't stop them when they want to. Now they say, well, that's dependency. And then they need more and more to get the same effect over time. That's tolerance. So some people will define addiction as tolerance and dependency. And other people want to look for the street value and people just rapidly having to have more and more. Now, with Prozac, you don't see people buying huge quantities just to get high. So that's the language difference. But bottom line is, you can't stop it when you want to. You're going to develop tolerance, and over time you need more. So if you want to call that addiction, you can. Or some people don't prefer to think of it as such.
so why do you think so many physicians say, like, I've never seen this before? And here you are since the 90s with all of this experience telling us that you see it extensively.
Well, chance favors the prepared mind. Confirmation bias. They have heard over and over and over again, these drugs have almost no side effects. They're safe. I can remember one issue of the Journal of Clinical Psychiatry and Anxiety Disorders. And they went through OCD and panic disorder and generalized things. Every single article ended with the same conclusion. These drugs are safe and effective, have almost no side effects. So that when doctors hear that, that's what they think. I can tell you a great study about benzodiazepines, where this was done many years ago, where what they did was they didn't tell the doctor what drug the person was on and gave them a case history of somebody becoming increasingly dependent on a drug. And this was back in the days before Valium was thought to be habit forming. So the doctors, when they just looked at the case studies, they would say, oh, this person's got an addiction problem. But if they were told that it was a benzodiazepine, it was Valium, they didn't have the same opinion. So the opinions of what people see are often formed by what their expectations are.
Makes sense. So you wrote a really great book on informed consent. Do you think most SSRI patients are getting informed consent when they're
Well, they're not. They're not getting anything. The doctor hands them the pills if they got samples and say, here, take this. You know what? If you give them informed consent, proper informed consent, hardly anyone's going to take these pills.
What is proper informed consent? I mean, I suggest everybody, if you want to know the full gamut, the book is great and it details it all for you. But maybe just for people who are listening and new to this, what are some things that...
Well, that's not by any means comprehensive informed consent. I just hit the big points. Like number one, you may not be able to stop this drug, even if you want to and are having side effects. And warning, you may never have another orgasm, even after taking this for a short period of time. The drug may make you suicidal. And then, of course, the drug, malignant weight gain occurs a lot, where it's just so out of proportion somehow to what they are eating. I remember one woman who put on, she was a tiny little woman, and she put on 60 pounds, and she had some money, and she hired a personal chef and ate only what was meals were made. She couldn't lose the weight, and she had a trainer. So I talk about the weight gain, suicide, sexual dysfunction, not being able to stop the drug when you want to. I don't remember which other big ones I might have put in there. But, that book is really actually written more for the person, warning for the person who wants to stop it.
Yeah. As opposed to just getting started. But it's good to consider if you're thinking of starting the medications too, certainly.
Well, those are the big things. The idea, you may not be able to stop this once you've started it. I've seen people who couldn't stop it after just taking it for a month. Sexual dysfunction after 3 days.
Yeah.
So, yeah, people should be aware of that. So I would tell people about that. People would come in and want an SSRI. Almost nobody would take it. There were some people who would say, I'm suffering so much, I've got to do something. And then, it would be, maybe the risk benefit is different. If your life today is going absolutely nowhere, maybe it's okay to take a risk on the future. But most people just, after they hear that, they laugh. They say, oh, I'm not there.
Yeah, as somebody who's been through withdrawal syndrome from psychotropics myself, I love the idea of informed consent. I think I probably wouldn't have taken the meds either if someone would have told me half of the things that were possible at the time of prescription. But I often wonder, is true informed consent really possible? Because the things that happen to me and my body, and also people that I've communicated with who also suffered in the same way, it's so beyond the realm of normal human experience that sometimes there's just not even words to describe.
You're talking about akathisia.
Yes, right? I did have that as well.
I realized that's more about stopping them, although this can happen while you're on them too. But I realized that there's no way to give informed consent for akathisia. All you can say is it's the worst thing you'll ever experience, but that doesn't do anything for people.
Yeah,
that was the big reason why I had to conclude I wasn't going to taper people off anymore. Not that I don't want people to taper, but I was giving people a guarantee that I could taper them safely. And it wasn't true. I couldn't, no matter how slowly I tapered it, I couldn't guarantee, even after they got off of the drug, they wouldn't develop akathisia a couple months later. And one gentleman, he's a man in his 40s raising 3 children. He wanted to go off his 50 milligrams of Zoloft. And when I reduced him from 50 to 47.5 milligrams, he did okay. But when I went from 47.5 to 45 milligrams, I'm talking about monthly intervals, he developed severe akathisia. And it lasted a long time. I had to reinstate higher than the 50 milligrams. And I realized that, how can you give someone informed consent that this might happen? And also what I was doing was promising people that if I tapered slow enough, they'd be safe, but that wasn't true. So
what do you do now? Just leave it up to them if they want to try, and you'll assist them if they do, or you just...
honestly, I stopped.
Yeah.
What I'm willing to do is share my information and advice with people, but I don't want to preside over any more withdrawals. Honestly, the number of people who did really bad was too high.
Yeah.
Remember, most people try to go off it on their own. I think Fava's study said 50% of the people can just kind of go off of it. So those people aren't coming to see me. The people who are coming to see me are people who may have tried and failed. It's very rare for someone to say, I'm considering this and I want a doctor to supervise me. So they were a harder group to begin with, but
Yeah.
Watching the patients develop akathisia, and universally they were suicidal, not because they wanted to die, but the discomfort was so high they were thinking, well, if I have to last this long this way, I could always kill myself.
Mhm.
I want to stop right now for a second and just give a message, because the people out there with akathisia who may be watching this, almost everybody, well, everybody I've seen, it gets better eventually, which is the number one question people have. Am I going to last like this? But the people who had akathisia were so seriously ill. When I was an emergency room doctor, most of the people were not that ill. And so if I could not guarantee that I could do this safely, then I didn't think it was okay to really be doing it. Maybe if I was in a large academic center and I had, large support staff and a university behind me, but one guy in an office with a pencil,
Yeah.
I thought it was a bad idea. So I actually ended up stopping. But what I will do is if people call up, I will share what I know with them, or I'll even sometimes talk to their doctors too,
Yeah.
but then help them to get a plan that way.
Even talking to their doctors, I think, is hugely helpful. I mean, you just said something that kind of like sparked my brain a little bit, that you worked in an emergency room and people with akathisia were sicker than some of the ER patients. But I went to the emergency room with akathisia and they didn't recognize, so many doctors didn't even know how to diagnose akathisia. Why do you think they don't know what that is, or what they're seeing in front of them if we're so ill?
Well, the typical person with akathisia has just been prescribed an antipsychotic, and they're pacing. They get up from the chair and they sit down from the chair. I think the akathisia from the medication withdrawal is a little different. As I recall, your akathisia didn't come on until a while after your last dose, right?
It took about 4 months to kick in. Yeah.
I don't think there's any other doctor who's been talking about this besides me. I see all this wonderful stuff about tapering. We have tapering strips and tapering protocols, but I think it's all worthless unless they do a 1-year follow-up after that last pill.
Yeah.
It would be so helpful to know who is going to develop, I call it tardive, meaning late akathisia. Who is going to develop tardive akathisia? What are the risk factors? How can we know this?
Yeah.
That'd be really helpful.
Yeah, totally. So speaking of informed consent, lots of people who are harmed by these medications are talking about their issues with them, trying to educate the public. I personally think it's like a public health service to do that, to share your experience. But there's this whole group of people who take the medications and they tell us we're pill shaming by talking about these problems. So what do you say to that? Have you come across that at all?
Not really.
Yeah.
But imagine how you feel when you're taking you're taking these pills and you're reading on the internet that these pills are poison. And so they're going to defend their position. There's another interesting thing that's happening. One of the major websites on withdrawal is advising people not to reinstate when they develop akathisia after stopping the drugs.
Yeah.
And I'm getting called by a lot of people. Well, just this last week, 2 people called where the thing for them to have done is to have reinstated. But the website made them so afraid of reinstating. One gentleman wouldn't do it. And the other one, it's interesting, she was so afraid of reinstating that it looked like her own anxiety about reinstating overrode any beneficial effect the drug could have had.
Yeah.
So you have the websites, it's the only information available is going to be on the internet. If you want to know about the withdrawal problems, the doctors, and by the way, increasingly doctors are aware. I'm finding that out as I talk to people. But the information is going to be found on the internet. And there's a reason why it's better to do controlled studies and have objective information, because trends can occur and people can get swept away into them. Like the idea that reinstatement is dangerous. It backfires sometimes, but that's another thing I never saw in my office. So we need more studies on what's going on with this.
Yeah.
I like Peter Gacci's last Mad in America blog.
Yeah.
It's part of his book that let's just do away with these. They are actually on the aggregate doing more harm than good at this point.
Yeah. So one of my favorite things, and I quote it all the time in writings and when I'm talking to people, it's from one of your blog entries on Mad in America, where you say, like, the language around this is so messed up. You know, these patients who are having symptoms for long periods of time, typically, you know, they call it protracted withdrawal. And you say the word protracted is good because it talks about the time sequence, that it goes on and on and on, but that withdrawal is the wrong term, and then we should call it neurotoxicity. So, I mean, that means that these drugs are neurotoxins then if people are having neurotoxicity. But where did you come up with that term? And, you know, why did you come to that conclusion?
Well, first of all, I want to say that when you say the term protracted withdrawal to a doctor, they bristle. It's internally inconsistent. Withdrawal is something that we think of, you know, as a couple weeks maybe, and it's out of your system and you're done. So when you say protracted withdrawal, doctors don't have like a mental image of that. So that's a bad one.
Yeah.
I'll tell you where I came up with the term neurotoxicity. And it had to do with the absolute worst patients I saw with akathisia, who, by the way, for those out there, the benzodiazepines helped ameliorate their symptoms. They didn't suffer for this period, but it was 7 years. 7 years, and the akathisia went away. And incidentally, they tapered off the benzodiazepines without incident. 7 years is how long it takes to recover from a toxic assault of the nervous system. For example, when they were making the B-12 bomber, the big winged, it was a flying wing. I don't know if you remember that, but they were working inside. It was a big wing, and the workers had to go inside, and they were working with solvents and chemicals. And actually, it was so bad, they had people circling the plane to pull people out who might have passed out from it all.
Yeah.
And that's where I started reading more about solvent exposure. And like, I remember one woman, anything that had a nerve to it vibrated. Her voice, her hands, everything was wrong. And like the literature says, about 7 years later, she just spontaneously started to improve. Yeah. And so the analogy may not be a good one, but that's where I got the word from. It's certainly better than telling your doctor, I have a protracted withdrawal, because right away the doctor's turned off. Yeah. But if you say I have a neurotoxicity, they have a language to begin to meet you and talk about that. Yeah. That's not to say that, by the way, very sensitive people with akathisia, they're very, very sensitive to anything. It doesn't mean that it always lasts 7 years. That's just the worst case. How long did yours last?
I still have it, actually. I had my cold turkey in 2010, but I reinstated. So I came off in December of 2012. So I still have symptoms currently.
You know,
but my akathisia went away mostly with the reinstatement. Yeah.
It went away with the reinstatement.
The akathisia. I have protracted, symptoms, other symptoms, but the akathisia was fixed by reinstating a benzodiazepine. Yeah.
May I ask, are you still on it?
Oh no, I'm 9 years off now of everything. Yeah.
Well, let me ask you, I mean, just from my own education, the education of the akathisia drop in intensity, or is it still a large problem?
Well, I don't pace or anything, but I still have, like, if I get really worked up or anything, I can feel that same urge to like move and, run around. It's like under the surface, if that makes sense. It's not where it was, where I was like, at the most severe, I was running around. I had bloody, blistered feet because I couldn't stop moving. Yeah. So, let's see. Yeah. So back to like doctors being offended, by you coming in and telling them what you have. So instead of saying I have protracted withdrawal, we're supposed to say I have neurotoxicity so they can understand it better. But even then, I get so frustrated, even myself, like trying to say like you have a physical problem, right? From the damage from psychotropic medications, like say it's causing like neuropathic pain or something. And you're trying to explain to your doctor, like, I have this neuropathy, but sometimes you don't know if it's a new problem or if it's the problem from the neurotoxicity from the drugs. And as soon as I start to say, like, I was exposed to psychiatric medication and it caused this neuropathy or whatever the symptom is, it's like they glaze over and shut down, or they turn the conversation to like, so you have anxiety? Or they think I'm there like wanting pills or something. Like they can't understand what I'm trying to explain, that I need them to keep this in their differential as maybe part of the cause, but I'm also wanting to see if something else is going on. So how do you communicate effectively about this?
Boy, that's a good question. You need a really, really good doctor who listens to do that. And when you give them information that doesn't correlate with what they've been told, a lot of times the doctors get angry and irritated and emotional.
Yeah.
They don't kind of stop. I don't know what to do. I have a question. Do you still prescribe them?
Oh, well, I haven't been able to work since I was injured. So.
Oh, really? Oh, I'm sorry.
Mm-hmm.
I mean, see, the issue we're talking about isn't just a mild side effect, but a side effect of this magnitude. That's why I stopped tapering people. Yeah. We're talking about the possibility of, side effects that are disastrous. A surgeon came in to see me. This was he wasn't from the United States, but this was a guy who, in his country, he was fabulously wealthy, and he actually brought his beautiful new wife, who sat in the waiting room, and we're sitting there and we were talking, and I mean, he spent the whole time talking about how he thought he was going to have to kill himself, which, again, there's hope, there's benzodiazepines, but this is a person, I mean, he had so much to live for. But what was interesting in this discussion, it emerged that if he had this is analogous to tapering somebody off of one of these medicines. If he had a patient who was doing well, but they might not do so well in the future, and there was a surgical procedure he could do to make sure that the future was okay, but in an unknown percentage of the time, the patients who were okay to start with would become crippled and ill. Would he do such a surgical procedure? And the answer was unequivocally no.
Right.
So tapering comes with that same problem. I want to go back to something you mentioned. You mentioned that you stopped the drug cold turkey.
Yes.
I just wanted to comment on that, so many times people come into the office with the worst withdrawal reactions, and what they say is that they blame themselves because they stopped it too fast.
Mm-hmm.
And I think it's important for people to realize that I don't think there's any literature or anything that says stopping it too fast is going to give you the more extended neurotoxic type of symptoms. Because I've seen that in my patients where we went very, very slowly. In fact, they had no withdrawal all the way through until stopping it. And then the akathisia came up, a month or two later. So, I mean, it'd be helpful for people to know that just because they stop the drug quickly or all at once, that may not be the reason, or that's not the cause of the prolonged symptoms.
I see. Yeah.
People blame themselves horribly about that.
I don't, well, mine was medically advised, so I have someone else to blame, but yeah. It was, in hindsight, I would not have done that, but I understand your point that I could have tapered very slowly and still had the same outcome, really, or similar. Have you heard about the concept of with benzodiazepines and alcohol called kindling, where each successive withdrawal is worse? Do you think
I've heard about that? I know who's promoting that, and I disagree with her.
Oh, I was just going to say, do you think it happens with SSRIs? Or I sometimes I hear people in the community say well, my SSRI withdrawal was horrible, but my benzo withdrawal that I did first was not so bad. But then sometimes you hear it in reverse. And I wonder if it's more about the sequence, if there's a kindling phenomenon, the second drug is harder only because you've already destabilized your nervous system coming off the first one, perhaps?
Well, as I understand it, when we talk about kindling and withdrawal, that each subsequent withdrawal is going to be more difficult. So if you stop it and go back on it, stop it and go back on it, each withdrawal will become more difficult because of a kindling effect.
Yeah.
And that hasn't been, okay, there are patients who go on and off it and on and off it, and it doesn't get worse. I will say that people who have really bad times going off of SSRIs are likely to have a bad time next time they try it. Is it worse? I don't agree with kindling. It's a term used anytime they want to invoke a positive feedback loop. It's not just about tapering off the drugs. It's about traumatic kindling leading to greater PTSD. It's a metaphor that allows you to talk about positive feedback loops. Getting back to what you said about the sequence, because benzodiazepines will ameliorate a lot of the SSRI withdrawal symptoms, I tend to take the person off the SSRI first and do the benzodiazepine afterward. I don't have a lot of experience with the reverse, so maybe I'm not working that way.
Actually, somebody had a question about that. Since you prefer that order, they want to know, is there a risk of then tolerance withdrawal while you're waiting on the benzo, holding on the benzo and you're tapering the antidepressant first?
I guess you could say there's always a risk. I don't really see that. My other experience with the benzodiazepines, as opposed to the SSRIs, the duration that the people have been on the benzodiazepine is not as significant as it is with the SSRIs. So that a person who's on an SSRI for 3 months is way better off trying to get off it than a person who's been on it 2 or 3 years. This is just one person's experience, but I haven't really found that it makes that much difference if a person's been on a stable dose of a benzodiazepine for 6 months versus a couple of years. they seem to have about the same degree of problem, if that.
Yeah.
So, I mean, I suppose there's always a risk, right?
Mm-hmm. Yeah. So what kind of interactions with colleagues have you had about, your patients who are struggling with coming off of these medications, and how, like, what's the reception from other psychiatrists or people in the mainstream that you interact with?
Well, my other physician friends don't have any trouble with this, but I don't know, psychiatry is a mixed bag. So I'm not sure. Sometimes people say they agree with me, and I wonder if they're just shining me on, being polite, and really don't agree with me. My office was in a house, an old Victorian house that another psychiatrist owned, and like about 1998, I commented that Paxil seemed like a particularly addicting drug. Oh, he just shouted at me. You need a controlled study to determine that. But controlled studies are to determine efficacy, not to determine side effects. Right. So I don't talk about it too much with other psychiatrists. Sometimes I try to find other doctors who will cover for me, and I talk about the tapering, and I'd say more often than not, the people who are polite to me disagree with me, but they're just being polite enough. They don't want to call me names. Sometimes I've had a couple of people do that, but I guess I have to say I stopped really discussing it.
Yeah. Well, it's funny. I mean, some of the response I get is like, well, your experience is anecdote, but it's like, they want to use that when something goes wrong. But when when a patient comes in the office and they just say, I feel anxious, or that's also anecdote, is it not? I mean,
well, yeah, it's one person's observation and experience. But clinical observation is the platform upon which research is done. They don't do research out of the clear blue. They do it because there have been clinical, observations. Yeah, it's tricky. I mean, basically, look at these drugs are here to stay. These drugs they're not going away, and I don't really think that. I mean, I'm really glad that there's finally more studies actually being done on withdrawal and tapering, but they can't really match the onslaught from the drug company that keeps coming out. And then they keep giving the educational conferences to the doctors, and even good doctors, good people, they don't always know when they're being fed propaganda. Yeah. And at the same time, you do realize there's so much medical misinformation. There are so many people claiming one thing or another thing. So the doctors pretty much stick to the straight and narrow. This is what I'm learning, from, as Bob Whitaker would say, from my guild. This is how we do it. And that has its merits, because a doctor shouldn't be going off on conspiracy theories or too much hearsay. So it's a rough situation. I don't know how this is going to end. I can say that it appears to me we're polarizing into groups of people who will not take these medicines, and other people where they and their whole family are taking them and swear by them. Right. So you say they're here to stay. Let's say I give you like this huge platform. You're on TV where everybody can hear you, and you have a microphone and the whole world is listening. What, after all of your experience with these drugs, what is your message to people considering taking them or coming off of them? Listen, if you give this big platform and you start talking, people are just going to say you're a conspiracy theorist. Okay. There's nothing you can do. We live in an age of conspiracy theories and misinformation, and people thinking vitamins are going to keep them from getting coronavirus. What do you do? Yeah. You ask me, what would my big message be?
Yeah, I mean, what would it be if people would listen?
I don't know. I think the most important thing is human beings are highly variable,
Mhm,
and we've medicalized emotions.
mhm.
And then I don't think any of these mental illnesses or diseases, not even schizophrenia, these are uncosmetic stress responses,
Mhm.
but we've never been able to demonstrate a pathology underneath any of them. I
Yeah.
think that human beings who suffer do best with compassion and understanding.
Mhm.
It's not like a dazzling message, but I think it's pretty obvious.
Right. Okay, so we have a couple quick questions from the audience before we get going. Somebody said they're tapering an antidepressant very slowly after 25 years. Hypersensitivity, night terrors, despair, and apathy. Is that normal in your experience for withdrawal?
25 years,
Mhm.
if that's all they're doing well, yes. No, that's normal.
And the big question that everybody wants to know, does it go away? I mean, did you have patients that even though they had bad withdrawals that lasted a long time, did they regain their lives? Did some people, 6, 7, however many years go on to get better?
Yeah, they did. In fact, you're the one that's lasted the longest that I've ever heard of.
Okay.
But
Do I get an
but
award or anything? No, sorry.
I was just surprised because I didn't think it did that. But I think that yes, it goes away.
Mhm.
And what what I did also, I mean, when people come to me for akathisia, they don't love me. I become associated with the problem, and they just can't wait to get away from me.
Wow.
So they hate it when I contact them years later to follow up to see how they're doing. But I have done that. And yes, it goes away, it gets better.
Okay.
And except for you, I
Yeah.
haven't heard of anything lasting this long. So,
Okay.
and I'm sure you're going to get better too.
I hope so. Thank you. All right. So last one. You stated that the people who do best on SSRIs were the one traumatized as children. What about them? What about those who are traumatized as a result of psych med withdrawal and tapering as adults?
Well, I wouldn't give them drugs. I mean, it's a terrible trauma, and people feel alone and betrayed. And when you have a problem, basically they're going to tell you you're the problem and that you've developed bipolar. That's what they do over and over. You've developed bipolar. So it's very traumatizing. And I think probably a good support group is the best help for that kind of trauma.
Yeah, I agree. I got lots of great help in the support groups. So, okay, Dr. Shipko, I've taken an hour of your time, so I don't want to take any more, but I'm so glad that you took this afternoon to come. Well, it's morning where you are, but to come chat with us and answer all these questions. Do you have any closing thoughts or anything you want to say to anybody listening before we go?
Oh, no, I think I've said most everything. It was a pleasure talking with you. I really enjoyed this,
Thank
and
you.
I hope that this is useful to people.
Yeah. And what about, so I know, I mean, I had heard the rumor, I guess, that you were not seeing patients anymore. So just for people listening, if somebody wants your services, what do you offer and where can they find you?
What I offer is educational consultations, and I can be found at the phone number next to my name on the internet. But yeah, I had to close the office. That doctor, the Paxil denier,
Mhm.
he was a COVID denier too.
Mhm.
And when we went into lockdown, he just wasn't going to do anything to protect himself. And I had to make a decision about whether it was safe to stay in the office or not.
I see.
He ended up getting it. It wasn't safe to stay. So I
Mhm.
haven't reopened. I don't know what I'll be doing in the future, but I am easily available by phone, and I'm happy to share what I know with anyone who calls me.
Okay. Awesome. Well, thanks so much for all your great work in this arena. I mean, I know there's so much more to do and we have so much more to learn, but you have added so many things to it to think about. And resources to share with people. So thank you so much.
You're very welcome. And you keep up the good work too.
Okay, thank you. So thanks
All
everybody
right.
for joining us. We'll have more interviews like this to come every week or so here on our Facebook page. They're always listed under the events tab. If you haven't seen the film Medicating Normal yet, check out our website at medicatingnormal.com/watch. And if you'd like to support the outreach efforts of the film to bring the film and conversations like these to communities worldwide, you can make a donation at medicatingnormal.com/donate. Thanks everybody again for joining us, and we will see you soon. Take care.